Right, so guys, this is a talk on a career in public health. We've got Roger Harrison here with us from the University of Manchester, who's just going to talk to you guys a bit about a career in public health and then just answer any questions you guys might have. And then, yeah, you can take over from here, Roger.
Great, thank you very much. Well, good morning, everybody, and especially to those of you who may have struggled to get on. I don't know about you, but every time I get invited to attend or speak at a conference, I find that they use different platforms and it's challenging in itself. Or maybe I'm just getting a bit old and finding all these changes with the technology just too many now. But anyway, I'm here speaking, so of course that's the most important thing. But it'd be even more important if there's people at the other end listening. And please, will you use the chat box to, either give me feedback about some of the things you might want me to talk about. I was invited to be part of the panel, so hopefully there are going to be one or two other people who are going to be talking as well soon. But mainly, I'm just going to say a little bit about my job, really, the career that I've come into, how I've ended up where I am, the types of things that have inspired me, some of the qualifications that I have taken along the way, and then I can answer people's questions or queries. So I'm currently a senior lecturer at the University of Manchester, and I've been working there now for a number of years. And most of my work is involved teaching on a master's program in public health, which is until recently was a fully online distance learning program. And now it's including more and more face-to-face and what tends to be called blended learning options as well. So as much as I can struggle with some technologies, such as the conference this morning, generally I'm quite au fait with using online methods for teaching, for supporting students. And when I say students, that means people of any age, right through literally from primary school, right through to those of you who are doing masters or PhDs. So how did I get doing what I'm doing now? And sometimes it surprises me as to how I've got here, because I was never one of these people at school who had a burning ambition to be a senior clinical lecturer in public health at the University of Manchester. I'm not sure many people have that type of ambition, and there I'm sure some people, and hopefully more people now in schools, primary and high schools, are starting to get interested in public health. And as horrendous as COVID is, the coronavirus, let's face it, is pretty bleak. The interesting or exciting thing around it is that everything that is being talked about at the moment, be it to do with the economy, to do with vaccines, to do with surveillance, to do with epidemiology, to do with public education, is all public health. And that's one of the reasons why I love this topic, because there's so much variety. So I started out going to university a little late. I was 21 when I went, and I knew I wanted to do something that was related to organizations. And I was quite interested in health, and I was also interested in computing and informatics and systems design. So I did quite a generic degree, which was called Public Administration, which introduced concepts such as sociology and politics and economics and government and public administration. And it was while I was doing that degree that I did a placement year working for a health authority down in London. And I was in charge of the data collection process of some field work that was taking place that was assessing the needs of older people. When I say in charge, I was a placement student, so I had a few tasks to do. I didn't have charge of the whole project. It was quite a big project, actually, and a lot of my tasks were making sure that the information people had entered into the online questionnaires and things like that into the computers was all uploaded properly, running some standard reports. But I got more and more interested in actually the quality of healthcare that was being delivered and the differences between what patients and members of the public were wanting and what was being provided, and this sort of huge chasm that in some areas was taking place. And I remember I met Derek Jarman, as some of you may know, you may have come across the Jarman Index, and he is an epidemiologist, of international rank. And I remember being at a meeting with him just by pure chance, and I was fascinated by his job title. Somehow the word epidemiology just stuck with me and just really grabbed my attention. Once I graduated, I got a job working in clinical audit as a clinical audit officer, and I was working in primary care, and my job there was to help GPs and primary care workers develop routine audits to look at the effectiveness of the care that they were giving using an audit model and looking at certain procedures or stages or standards to assess their performance and the ways that they were delivering their care. I really enjoyed that job, and it gave me a really good perspective on the different ways that primary care itself was organised and some of the challenges within that. I was working in London, central London at the time, and it was fascinating really to realise that on Oxford Road there's actually GP practices, which for me at the time was a huge revelation. I just thought it was shops and nightclubs. I didn't even realise that people lived in some parts of the city off those busy roads. I moved up to Manchester for personal reasons, and my job in clinical audit continued, but I think I was getting a bit frustrated at not knowing some of the answers to some of the questions that other professionals had around the types of interventions that needed to be delivered, or the ways in which they were best to be provided to meet the needs of local people. Particularly, I was working around chronic disease management and diabetes, asthma, coronary heart disease. I was fortunate to get a fellowship to study with the Centre for Cancer Epidemiology. And even though I didn't have a particular interest per se in cancer, this was a generic fellowship that was associated with the regional randomized controlled trial support unit. And I was just fascinated by this whole concept of being able to randomly allocate people into different groups at a population level. I don't necessarily mean at an individual level, but where we could allocate areas or health centers or I don't know, even different countries, if you wanted to be allocated interventions and control procedures. And my thesis that I did was actually looking at patient information for people who are having treatment for cancer and looking at meeting their emotional needs and also their information seeking needs. While I was doing that, I got more and more interested, I suppose, in the academic side of things rather than the practical side of things. And I think I thoroughly enjoyed doing my master's. But I also like the idea of meeting patients and just listening to what some of their needs or concerns or fears were. And I was fascinated how after the patients had seen their consultant, they then came to see me to follow some questionnaires, and they would start to ask me quite complex questions, which they hadn't had either the confidence or I don't know what it was really, but they didn't feel that they had been able to ask their doctor certain types of questions, but they saw me more as a general, I don't know, human being, I suppose. Not to say that they weren't seeing their consultants as humans, but there was something where the professional divide was preventing them from feeling comfortable in asking certain questions. And I think that fascinated me as well, that sort of divide between different levels of care and patients. So still with my academic sort of interest on, I went to work for a health authority in their public health department. And my role there was to help them identify best evidence to meet local health needs. And this was needs in the populations. And it had to start by actually mapping out what people's health needs were. And I don't mean their health needs in terms of, you know, have they been to the asthma clinic? It was much more generic. It was health needs in terms of, have they been able to afford to buy fruit and vegetables this week? Have they been able to get to the job centre or to get some peer support to help them find work? Because we know that all of these things are so directly related to people's health now and in the future. So these wider determinants of health started to take on more of a fascination for me, really. And that whole rainbow diagram that many of you will have seen before, I think that's just as much today as it did originally. My PhD was a bit of a curveball, really, and it was looking at the effect of getting people to eat sardines on the treatment outcomes for cardiac arrhythmias. Basically, that's what it was doing. It was looking at if we can get people with cardiac arrhythmias to eat more oily fish, such as sardines, does it reduce the effectiveness of their treatment? It was a very complex study, but it was really interesting to do because it was situated in the community, working with local people, local doctors, local nurses, local patient groups, and getting people to think about their diet and how that might impact their treatment outcomes. But also at the same time, it was a complex trial using the MRC's methodology for evaluating complex interventions. And some of you who have either personally or professionally tried to support people in changing their diets, that in and of itself is complex. It was a very pragmatic study, which basically in trials format means that we had very wide eligibility criteria, rather than it being something that you might see taking place at one of these clinical trials units in some of the drug companies. My fascination, I suppose, across the boundaries has continued. And after I got my PhD, I continued to work in the NHS and then realized I needed to do some training in public health. And I went to do the Masters in Public Health at the University of Manchester. And I was only able to do that Masters because it was an online program. It was one of the first online programs, probably in the world, but certainly in this country, which started way back in something like 2011, when online teaching was very, very, very new, novel, and different. So I did that MPH and I just loved the topics. I particularly liked the idea of evidence-based practice when it's applied to communities and populations. And I particularly liked epidemiology and some of the, I suppose, GIS, geographical information systems, social networking, that side of things. So I suppose to give a divide, I was much more of a quantitative than a qualitative person, though that's very much shifted over the years. Now I really enjoy my teaching role, which is my full-time job. I don't have a research profile anymore. I spend most of my time dedicated to educating younger people and people often who are mid-career, looking either to change their career in a different direction or to expand their existing skills. But I'm also lead in our division for social responsibility, which is an agenda the University of Manchester has. And my particular topic of interest is antimicrobial drug resistance. And I'm involved in running some public engagement events, some education events, working with students going into schools. And I've been doing quite a lot of work actually in Africa, supporting students over there to learn more about this topic. The attractive thing, I think, about public health as a profession is the extent of the variety that it can include. And it really is a profession where you can follow your interests to an amazing extent. When some students join our master's course, they might say that they don't have much public health experience, but actually we all have public health experience, don't we? Because we're members of the public, and really that's what public health is all about. It's around looking at the relationship between health and disease, the impacts on that, and trying to improve that, trying to reduce inequalities in particular, which is a massive concern more and more as the pandemic has such far-reaching effects. So I think that's probably as much as I can say about my work really, and how I got into what I was doing. There's been certain people, I suppose, who've inspired me over the years, and I think it's really important for all of you to look out for people to go and talk to more, to learn about the opportunities that might be available, to network. I think networking is so incredibly important more and more. Our worlds are becoming smaller, really, not just because of the electronic network, but as we all know, it's a lot easier, it's a lot quicker to get around the world and meet different types of people, different groups of people. So I think networking is really important. I think public health is a profession for people who are really interested in making change, who are particularly interested in supporting some of the vulnerable groups in society, or the groups in society where their needs are not met to the standard that they ought to be met. It's a career that can bring that brings in prevention and also planning for the years ahead. It touches health economics, it touches art. We run a unit, Arts in Health, because we know more and more how important that is to health and general well-being in society. So please do let me have any questions that you might have about this in terms of how you might go about. Oh, one thing I ought to mention as well is that in the UK, the Faculty of Public Health is the professional organisation. It's well worth looking at their information site as well. And just like you can become a consultant in a medical profession, you can become a consultant in public health. It's recognised by the GMC. You don't need to have a medical qualification. In fact, more and more it's recognised that we need such a plethora of different interests and skills and professional backgrounds working in public health, because it is such a wide variety, it's such a wide portfolio. So I think I'll leave it there. I've sort of spoken at lib for quite a long time now. I may have gone off the agenda a few times, but that's quite normal for me and I've got used to it. So if there's any questions that people have got, or if there's something you'd like me to touch upon a bit more than either, I don't know, feel them towards Bridget or put them in the chat room. Thank you.
Hi, Roger.
Hi.
You guys hear me?
Yeah, we can hear you.
Oh, hello.
Hi. How's it going?
Hi.
Yeah. So I think so. Roger, I managed to tune into a bit of that at the end. So yeah, thanks for that great summary. I'll just give a quick summary of my own kind of path in public health, and then hopefully we can open it up to questions if people have any. So I come from a medical background. I studied medicine at King's. Whilst I was at King's, I did a master's in public health there. In sort of between my third and fourth year, which is what we kind of consider an intercalated degree, which is fairly common in medicine. And then I practiced as a doctor in Leicester and Kettering, just in a range of kind of medical specialties, and did the foundation program. So as I came towards the end of my foundation program, I did an academic sort of block, which is essentially 4 months of research. So during that, I actually spent some time with a health economics group. And obviously following on from my MPH, my Masters in Public Health, I knew I was interested in public health, but this really gave me a bit more of an opportunity to learn a bit more, sort of the more technical academic aspect of public health. And that project focused on looking at health taxes, which is a very kind of topical issue. And I think that's part of the appeal of public health, is that you're working on things that are, things that you'll see on the news and things that really affect the masses. So I looked at health taxes. I went to, got the opportunity to go to some workshops and really look at this from an academic angle to some extent, but more from a practical angle. To some of the workshops I went to at the Centre for Global Development, they had the policymakers from different places. And some of the really fascinating stuff that I found was kind of considering public health interventions from implementation. So, you've got economists sitting around the table, policymakers, all of these people involved in people's health, in the public's health. And what are the barriers to kind of thinking about something like a health tax, which many have advocated for and there is significant evidence for, but what are the challenges in actually kind of translating that? And that's what got me a bit more interested in that sort of evidence to policy aspect and the more practical aspects of public health. So after that placement, I went on to do the public health training program. So Roger mentioned the Faculty of Public Health. They are the board that run the postgraduate training program in public health in the UK. As Roger described, you don't have to be a medic to apply. So it used to be the case, and I think it still is in some countries, that they've limited public health to medical professionals in that kind of postgraduate training program. But the UK, recognizing the variety and the kind of value that's brought from other professionals from various backgrounds, widened the sort of access and the eligibility, I think, more than a decade ago. So you do work with a wide variety of people when you're on this program. There are other medics as well. And I think working in such a kind of multidisciplinary area is quite exciting, because you do learn a lot of things that you wouldn't have necessarily otherwise. So since starting on the program, I have basically worked in local government. So this is where you work with a local government public health department. And I guess the focus of that work is more on, like I said, the translation and the implementation of public health evidence, working with, councillors, local leaders, MPs, etc., to try and deliver, a particular public health agenda and to meet population needs, really. So, that was a fairly interesting sort of introduction, I think, to public health for me, from, in terms of my first real job in public health. It was the various different projects that you'll work on, and some of which have been touched on by Roger, the wider determinants of health. So thinking about how does housing, employment, education, how do these things impact health? And what I was doing was more focused on what we call healthcare public health and health protection. So doing things, healthcare public health is essentially thinking about health systems and how do you deliver health services and systems that meet population needs whilst minimizing inequalities, essentially, is what healthcare public health is about. And then health protection is about, what you're seeing with COVID-19, essentially, outbreak response and infectious disease, epidemiology, etc. So most of what I did in local government was kind of cardiovascular disease prevention. We did an evaluation of the local obesity services and looked at how they could improve. And we also designed a strategy on cardiovascular disease. And then from then I went to Public Health England, where I did some work initially with the clinical guidance cell. So this was sort of at the start of the outbreak, towards the early part of this year. Public Health England were having to release quite a lot of guidance very quickly, and this was a very elaborate operation. So I worked in just one small part of that. Daily work was kind of writing guidance documents in terms of clinical aspects of PPE, etc. It was also responding to various different bodies. So Public Health England would get inundated with questions and criticism as well from different areas, and so I was in part responsible for some of the kind of correspondence going back and trying to explain why certain things were being done, or that things were being advised in the way that they were. And after that, I moved to health protection within Public Health England. So this was essentially part of the new service that PHE have set up in London called the London Coronavirus Response Centre. And this is essentially a health protection function that has existed for a long time for other diseases. So like meningitis or E. coli or, Legionella, any other infectious disease, there is a health protection function where there's a team who work on kind of contact tracing and identifying the source of infection and preventing onward transmission to high-risk contacts. And they established this new service specifically focusing on COVID-19, just to do that for COVID-19. So that's where I started working. The bulk of the job was kind of, responding to outbreaks. So this is essentially a part of Test and Trace, where Test and Trace will identify people who have COVID-19. They'll then classify those cases into whether they're complex or not, judging that complexity by whether it was associated with an institution where they could have been spread to other people. And then they'll cascade it down to, local health protection teams, or in this case, the LCRs. So, the bulk of what you're doing is working with schools, care homes, workplaces, hospitals, trying to essentially do, similar to what you do in clinical medicine, where you initially take a history, establishing who the cases are, any vulnerabilities, what the links were between them, the timing of infection and symptom presentation, etc., and just trying to provide support, knowing that that support is fairly limited at the moment because of a lack of vaccine and a lack of treatment, but at least support in terms of advising who needs isolating, who needs testing. And I think hugely, in terms of limiting transmission, it's no doubt had some effect, but I think the main effect has been kind of psychological, moral support for businesses, for schools, for stakeholders across the entirety of the public, to know that there is a service there where there's someone you can connect with who will advise you based on evidence and guidance and expert advice. And I think that the service has been hugely successful in that respect, which often isn't necessarily reflected in the metrics that we measure. But that was a very good experience for me, and I still continue to do that role. I've recently gone back into local government for a short period of time, and I will be going to UCL from January to do some more kind of academically focused work in public health as part of this training program. So I'm happy to answer any questions about my own path, and particularly if anyone has any questions about the training program. And yeah, I'll hand it back to you now. Thanks, Bridget.
Yeah, I think if anyone's got any questions they want to ask, just feel free and I can pass it on to the speakers. I think I can start with a few for both of you. Sort of what prompted the career in public health for you guys?
Gosh, shall I start with that? I was going to ask, I was going to pass that question over to Vageesh. So for me, my career, I suppose, has been slightly unplanned. And I think what is underneath it is my fascination with the way in which different parts of society link up. Whereas I think for some clinical people, perhaps their fascination is with a particular disease mechanism. My fascination is with the mechanisms of the world and how that influences people's health and how people's reactions and response to health. And I think more and more, my interests have changed. You know, I've been working in public health for 25 years now. So, and societies has changed. And I think I like the fact that with public health, the profession has remained, you know, particularly consistent in terms of what is public health all meant to be about. You know, it's been consistent really since the mid 1850s, since we got like the poor laws and the sanitary laws coming in, you know, for access to water in this country. But around all of that, everything else is just like constantly changing, and often doesn't change in the way that those of us working in public health would like it to change, and certainly not recently. So I think it's always bringing up some amazing challenges. So it's like never boring, you know. It's just absolutely, we're never waiting. Like, I don't know, if I was a clinician, I've no idea, and I'll get clinicians sending me hate mail now. I was never like, you know, been waiting for the next drug, and that might be like 15 years down the line before give a new treatment. With public health, every week there's some new challenge taking place, be it in my local community, because the bus route might have been pulled off, and that means that some of the poorer older people where I live can't get to go to the supermarkets where the fruits and vegetables are cheaper. Or it might be due to the fact that in Rwanda, you know, they've got, or well, in Rwanda they're doing amazing actually around COVID. It might be places like in Uganda where there's huge concerns around antimicrobial resistance, just as there are in this country. So I think it's that pace and that excitement, and there's always something more that you can be learning about. And I think it's a profession as well where you've really got to be interested in continued learning and development.
Yeah, I'd echo much of that. I think the first point is that, you know, when I was in clinical medicine, like you said, there are not that many developments day to day in terms of the profession, you know. So the way we treat TB or HIV or whatever, these things have changed gradually, of course, but they're broadly the same. And the way you practice clinical medicine, you know, now versus in 5 years' time will be very similar. And one of the different aspects of public health, I suppose, is that every day there is new information coming out. And COVID is a perfect example of that. Every day there are hundreds of new papers, tons of new evidence, tons of new things to understand and then use to try and inform what we're doing. So I do enjoy the fact that it can be considered fast-paced in that particular way. The reason that I went into it was because I enjoyed clinical medicine, to be fair, and I still do. I do continue to work occasionally in clinical work, and I enjoyed the challenge of, you know, diagnostic kind of medicine and the human connection that you have when you're treating an individual. But for me, the issue was that, you know, every day I was going in, working really hard, and then at the end of the day, when you're managing a ward, it's about how many patients you've discharged, and then the next day you come in and the ward's full again. So it's this lack of long-term impact on the kind of upstream determinants of what's happening. So you're seeing on the ward the result of a lot of other stuff that's going on, and I think I was a bit frustrated about the ability to affect those more upstream things, and that got me more interested in prevention and thinking about, okay, you know, this is great, I've put a drain into this guy who's got alcoholic liver disease, but we know he's going to come back in 6 or 8 weeks time, and that we have to do the same thing again. And, you know, how are we really making that much of a difference here? So that got me interested in prevention and thinking about, you know, if you really want to make a big difference, you need to engage beyond the clinical environment alone. You need to understand the broader issues affect people's health. And, you know, that's what pushed me towards doing the training program, because it's a good way to develop those skills that you otherwise just is quite hard, I'd say, to get those skills. So yeah.
We've also got a good question here from Katie, which I think is quite relevant, just talking about how COVID-19 has had an impact on any of your jobs.
Yeah, I can take this one first if you like, Roger. Yeah, COVID-19 has basically taken over the job, I think. And I don't know what other people's experience is, but, you know, public health now versus what it was even a year ago is very different. And entire new services have been created. You know, you're talking about teams that have literally been created for COVID-19 that did not exist before. So for me, it's, you know, particularly when I was working in health protection, that was all I was doing, was responding to COVID-19 outbreaks and, you know, going kind of having an understanding of the guidance on various different things and providing support at that kind of community level. So that radically changed my job. I think moving back into academia shortly for a short while, it may have less of an impact, because the projects I'll be doing will not necessarily be directly because of COVID-19. And so, I mean, the message is that it probably has a slightly differential impact depending on where you work within public health. So, you know, those of us if you work in health protection, the burden of things like meningitis or TB or whatever, the other infectious diseases that you may normally see day to day, has decreased whilst you're taken over by COVID. Whereas, and to some extent, that's happened in local level government departments as well, where they're having to focus a lot on COVID at the expense of other things. But there may be a bit more of a balance there. And then maybe in academia, there's the potential for more balance depending on what your interests are and what kind of academic you are. But I'll let Roger give the kind of academic view.
Thanks. From my sort of day-to-day job, it hasn't had a huge impact. For many people involved in education, teaching at the university, it's had a huge impact because so much more has been transitioned to online, whereas I was already teaching online. So it's sort of like, to me, it's been, I've like welcomed my arms to some extent. Suddenly the university has found money to be able to put in to support online distance learning. And I've been, you know, saying for nearly 12 years now that we should be doing far more online distance learning. And this idea of, you know, if we were looking down from the moon and you were looking at human beings trying to solve one of the problems of climate change, yeah, every day we're still getting to our car at 7:30 to do the school run and then go to school and then go to work all at the same time, creating masses of congestion. You'd be going, do all those people actually have to get into their car and drive to an office to sit at a desk in front of a screen that they could just do at home? So it's like really, I think, hopefully opened up some really positive opportunities. My interest, as I said, in antimicrobial drug-resistant infections. I think what COVID has done and hopefully will continue to do is to actually bring that even more to light, because I think Sally Davies herself, she calls it the silent epidemic. She says COVID is the lobster thrown into a pan of boiling water that suddenly starts to jump out, whereas antimicrobial drug resistance is a lobster put into a pan of cold water where the water just slowly gets hotter and hotter and it starts to boil, by which time the lobster doesn't know what to do. And I think that's the case really with AMR. So I think with COVID, it's getting a wider circle of people realize that, of course, the current pandemic is horrendous. But, you know, we saw in the newspaper yesterday, didn't we, in Denmark with the minks, and how they're now spreading a new mutated form of coronavirus. So we've got this whole interrelationship of zoonotic diseases, you know, which has always been there, but it's coming to light more and more. So hopefully it's going to get people to realize that actually COVID hasn't been a 2019 thing. This actually is going to be more and more what's happening because of the interrelationship between all the crazinesses that we as humans have done to the planet, and just just the way in which microbiology operates. So I hope it's going to get all of us to have a bit of a rethink, and I know we've had to have an acute rethink, but I think what's starting to happen now is people are starting to recognize that, okay, actually this isn't just here for 6 months. This is now going to be I don't want to say the new norm, because the previous norm was rubbish. So let's hope we can do something better. And it's going to be about, can we use this as an opportunity to re-envision how we as societies want to operate together? Judging what happens over in the West, hopefully it's going to be good news once they've finally counted. I mean, you just can't believe it, can you? One of the biggest superpowers in the whole of the world, and they can't even, get the election bit right. And I think, all of those things have massive implications for public health, because so many of us are waiting, to see who actually is going to be finally declared, what's going to happen. Because the WHO desperately, the World Health Organization desperately want America to be sending them money again, because they've pulled that money out. And that was worth a quarter of WHO funding. So there's huge implications for our massive superstructures, right down to my lady opposite, my neighbour opposite. She's in her 80s. She doesn't know. She was concerned to me, shouting across the street yesterday, should she be shielding or not? Because she's waiting for a letter. Well, she's not going to get a letter this time. So it's all about bringing, trying to see everything really is public health, isn't it? And trying to see where can we make links, but also where are some of these links needing to be changed, or what can we do in the future? Yeah, I don't think that answered the question really, but anyway, it's all said. I just want to pick up on one of the questions, sorry, Bridget, but one of the questions was around doing research work in public health, and also getting involved in public health as a clinician, but also without necessarily then going into public health full time and being able to maintain some of your clinical duties. And that's happening more and more, whereas we're getting people with split posts, just as we used to get a lot within some of the other clinical specialties between academia and health services. We're getting that more and more in public health, where there's people who are working within the university, and they might be teaching, such as I do, or they might be working on a research project, and they might do that maybe for 2 days of the week, and then the other 3 days of the week, they're then working perhaps for a clinical commissioning group, or they might be a clinician in a local hospital or in a primary care centre. And we get dentists, who study public health, because they're taking a public health perspective to their dental practice, and looking at how they can meet the needs of oral health, dental health in their communities. From the research side of things, and there's different routes really into the research. It can be, sometimes it's about applying for a job, research. There are jobs, just standard jobs within research, and that's often where you might be managing a project or involved in the analysis, or helping to develop a particular intervention, delivering the research. Or it might be as a fellowship, where as part of that you might do a PhD. You don't have to do a PhD always, but it might be a funded fellowship. Or it might be where there's some research where you're just going to be given a small stipend, and you're going to have to generate the rest of the funding to support yourself in some way. So there's a whole vast range of routes into doing research, and it doesn't have to be full time. So a lot of people who do research also, can continue doing their existing profession, as it were, and they're just wanting to either do some research in their topic that they're currently their day job is associated with, or in something that's just always been of interest to them, or using it. Another reason people come into public health sometimes, we find, is that they're using it as a linchpin to have a bit of a career shift. The best person I remember interviewing he was a postman on one of the Scottish Isles, and he decided he wanted to do something completely different, and he signed up to do the Masters in Public Health and went off, and got a job working in public health. So you can bring in people from these different backgrounds, and hopefully that touches up on some of the questions. We've still had a few people asking if you've got to have a medical degree No, you don't. Probably now more people who've got a master's in public health and are registered public health consultants and registrars probably haven't got a medical degree. So it's much more of a fluid profession where it brings in people from a whole variety of different disciplines. And I think more and more that inter and intradisciplinarity is being recognised for its strengths.
I guess it's also a question there from Charlotte talking about dietitians maybe being involved in pandemic responses, and just asking if there's other professionals that you work with in the public health field.
Vageesh.
Dietitians, yeah. So I mean, this is the part. So if I break this down, so public health can be considered in three broad domains. One is health protection, which is kind of infectious disease prevention and response. One is health improvement, which is basically what you're talking about here. And then the final one is healthcare public health, which I mentioned earlier, which focuses on health systems. So health improvement looks at the wider determinants of health. It looks at things like diet and how you can improve people's diet, but more from a population level. So as a dietitian, you're going to be involved in those individual interactions with people and trying to improve people's diet on a very individual level. As a public health person who may have a dietetics background, if you're working on obesity, you're looking at things that can improve obesity on a population level. So the day-to-day of that is obviously very different, but having that dietetics experience would be very useful. And there are many people who come in from dietitians and a nutrition background, and they develop these kind of niche areas within public health where they'll look at what are the nutritional interventions to reduce obesity. In our local area, there's a new pilot for a very low-calorie diet, a VLCD diet for type 2 diabetes to prevent complications. Stuff like that going on all the time. New pilots, new initiatives of ways to reduce obesity. I worked on a evaluation and basically looking at how the local weight management services that provided essentially exercise classes, nutrition advice. There's like a multi-component intervention that we call, and how effective was that? Because many people have ideas in public health and they say, we'll educate people, we'll tell people, make them more aware, or we'll give them advice or whatever. But actually looking at how effective is that? Does it actually translate into improvements in obesity, and how long do those improvements last, and how do you measure them, etc.? So these are the kind of things that you can think about and you'll learn about when you do public health. It's it's looking at the same thing as you might look at in dietetics or in clinical medicine or as a lawyer, but from a population perspective is the key difference.
And I think for some people, hopefully not many people in this session, but generally people find it quite difficult, I think, to make this transition from an individual effect to a population effect. And we find, certainly I found in my teaching over the years, that for clinicians, they can actually find it the most difficult because a lot of the clinical training is so focused on an individual, or not even on an individual disease pathway within that individual person. Whereas within population health, we can be looking at the whole world, or we could be looking at the people who live in my borough, or the people who live on my street, or we could be looking at everybody aged 7 years of age who lives in Trafford. So we carve up populations in lots of different ways, depending on our focus, really, or the types of things that we're trying to explore. And the other thing around public health, which we haven't touched on really, I suppose, is the opportunities it brings for people who want to go and work in other countries, and for people in other countries who want to learn more about working in their country or wanting to come over and work in this country. And we've got loads to learn in our whole care sector, really, from the way we do things in other parts of the world. I mentioned Rwanda. Look at the death rates in Rwanda from COVID. It's minuscule. If you believe the data, and they're pretty quite good in Rwanda, it's minuscule. Yet they're not a high income country. They're a landlocked country. How is that happening? Look at our country, an island that actually, on the face of it, one would have thought should have had some of the best control regimens going. So we need to, like, you know, in public health, we like dissect some of that and see what can we learn, what's portable. But also, a lot of people who work in public health tend to want to go and also do work for some of the charity sectors, some of the non-governmental organizations, and that doesn't have to mean relocating. You know, I do quite a lot of work in Rwanda, in Uganda, and Tanzania, you know, and I've only been to those countries twice. So we can do a lot of that type of work, you know, because of this platform we've got in front of us, without having to clog up air miles and pollute the world even more. So it brings in some of those, so some of that varieties, and I think that's really important, because what we have to shift is, we used to think, and really our paradigm still is that we need to educate people in Africa to do things the British way because we know best. Well, actually, you know, hopefully all of us in this room will agree that we don't know best. And what I want to see is us learning more from the way that some of the countries in Africa and other parts of the world do things to help us become as good as what they're doing. So this whole opening up, really, of borders and borders around the world. And I think public health is one of the best professions, one of the best positions to be able to do that. And the reason that got me onto that train of thought was the discussion around nutrition, because one of the things around nutrition isn't just the fact that we've got the obesogenic diets, you know, flooding us in this country, but at the same time, we've got a global protein shortage, you know, which is facing us. And we've got this climate change catastrophe on top of antimicrobial resistance catastrophe, all of which directly are influenced by and influence what we will then have available to eat on our plate and at what cost. So it has some broader aspects relating to nutrition as well, you know, the nutritional epidemiology, the nutrition in terms of food supply, and in terms of disease prevention and diseases that affect individuals and can affect societies as a whole. So the other thing that we need to be doing more in public health is opening up across veterinary, environmental, and human health. And we need to be, you know, learning more on public health programs and in clinical medicine and other degrees, more about those connections and disconnects, because actually they're having a far greater impact on my and your health today as we might actually appreciate.
Yeah, no, I was just going to say, I echo what you said about global health there. If anyone's interested in, you know, I guess international relations or affairs, or, you know, anything to do with the world, really, public health is one of the best areas to go into. And I'm definitely sort of more inclined towards global health, and I've done things with other countries, and you know, it's a great opportunity to learn about other cultures and to learn from them as well. You know, the kind of stuff you can get involved in is really kind of high level, high impact stuff. You can be advising a Ministry of Health in a country on a particular program, a particular intervention. You can be doing groundbreaking research where you're, you know, finding out answers to questions that haven't been answered yet. And I think that's a bit of a difference between, you know, UK-based public health, where we have a fairly sophisticated system, and then when you're working in public health in a developing country, it brings another dimension in, and it's very it's very interesting, very inspiring stuff. So I would encourage any of you who are interested in public health to kind of look at global public health as a potential, you know, opportunity.
Roger, I guess you've answered the work-life balance question.
I just love that question. I go into primary schools and I do like some careers work, and I talk to them about hand hygiene and different things. And the amount of times a kid, you know, somebody will ask the question, what's your work-life balance like and how much do you earn? It's like that type of question, isn't it? And I think it's just like any other profession. You know, so much of it is dependent upon, you know, you as a person, what you want to bring to it, and also some of the challenges. And certainly for people working in public health at the moment, well, in any healthcare at the moment, it's been pretty manic, and none of that could have been was really on the cards a year ago. But within all of that, there will have been some fantastic highs as well, and some great experiences, and things for people to look back on and think, God, did we actually manage to get through that? Did we actually manage to do a complete service evaluation and reorganization of Greater London in 3 months? And like those types of things. So it'll be at times where, like any career, it can be really full on. But I think with it, it's around, but what is it that you're bringing, and what is it that you're getting? What's the rewards for you? And I don't necessarily mean financial. I mean in terms of what is it that you're getting out of this as a person? And of course I'm biased. I think public health's the way to go, but I think it's not one of those easy questions. It's certainly not 9 to 5 all of the time, that's for sure. And certainly if you go down the academic route, because of the amount of studying I've got, 4 degrees, 5 degrees. And so, that's a lot of part-time studying. That's a lot of weekends and holidays and Christmases, sacrifice and things. But, I love doing what I did. So that's why I did it.
Yeah, I'd agree. I think the work-life balance is, it just depends. It varies. It's kind of how much you put into it. And it's a bit different, I think. The bit I'd stress is that it's probably more flexible than a lot of other jobs, like definitely more flexible than clinical roles, a lot less regimented. There's a lot more control over what you're doing and how you're working and where you're working and when you're working. That doesn't mean that you should work less. It probably means you can, but most people don't. And certainly, the more responsibility you get, the more senior you get within public health, it's trickier to maintain that work-life balance. And I think within the clinical world, it's often seen as one of those areas where you can have a good work-life balance, and that's a reason to do it. I'm not necessarily saying that's wrong. You can have a good work-life balance, but I wouldn't underestimate as well, the amount of work that goes into public health. It can be really, really stressful. It can be very full on and very intense at times. The main difference, I would say, is that it tends to be a bit more flexible compared to the clinical role, at least, which is what I can comment on.
And I guess our last question for sort of the talk, I think someone had asked a bit earlier on, sort of what was the best aspect or the best bit of your careers?
Tough one. For me, I think the best aspect I can say is, and this is largely down to my individual interest. So this is a very, it's a personal thing that it won't apply to everyone. But for me, I think it's the ability to affect change and influence things on a high level at a regional or national or even a local level, so that you're able to, use your ideas, use your creativity, use your ability to critique evidence and to look at data and interpret that, and then pull that into something that's useful to actually inform decision makers and advise people, and that eventually that's what leads to change at population level. And I think that's quite it's a nice position to be in. It's a nice skill to have. And it's something that, like, not many people have the privilege of, being in a position where they have the ability, the knowledge, the skill set to do that. So, I think that wide impact is what I would stress for me personally.
I was brought to mind a student that I taught about 3 years ago. And I remember at the time I got some end of year feedback. All students give feedback, and the student was really critical of my teaching methods and the course design and this, that, and the other. I was quite disheartened. And then about last year, so that's about 2-3 years later, the person had taken the time to write to me and said that they now realized, now that they've been working in public health for a couple of years, they now realized why I had done what I did in the way that I'd done it, and how it actually got them to learn so much. and to be able to affect change, you know, be it one person who can then go on and work in public health, that's then affecting change for a group of people. I think that's why, you know, I'm sure it's the same for all of us in this room. That's why we've signed up for these types of careers, because we want to make people's lives better, really.
Much to both of you for deciding to take the time up for your Saturday morning to do this.
Work-life balance.
It's definitely been really helpful and informative. Thanks, guys.